In this video I will discuss the oral cavity cancers. The oral cavity extends from the mucosal surface of the lips to the junction of the hard and soft palate. It does not include the soft palate, uvula or tonsils, which form part of the oropharynx. Oral cavity cancer is the 8th most common cancer worldwide, with an estimated 350,000 cases arising annually. While there have been significant advances in the understanding and management of oral cavity cancer, the morbidity and prognosis associated with it have remained largely unchanged. In this chapter, we will outline the etiology and epidemiology of oral cavity cancer, as well as risk factors for this disease, and highlight important geographical variations. Additionally, we will explore the investigation and management of oral cavity cancer. Lastly, we will outline emerging techniques and technologies utilized in oral cavity cancer treatment. Epidemiology. There is considerable geographical variation in the incidence of oral cancers worldwide, reflecting differing lifestyles and risk factor exposure. For clarity, and in keeping with the 11th revision of the International Classification of Diseases, ICD-11, we will include cancers of the lip, gum, tongue, palate and floor of the mouth as well as the rest of the mouth in oral cavity cancer. Cancers of the nasopharynx, hypopharynx and major salivary glands are excluded. The oropharynx includes the base of the tongue, the soft palate/uvula, the pharyngeal walls and the tonsils. Incidence. There are approximately 350,000 new cases of oral cavity cancer per year worldwide. The vast majority of these are squamous cell carcinomas, SCCs. In 2015, the estimated age-standardized ratio of oral cavity cancer was 5.8 in men and 2.3 in women per 100,000. This 2-to-1 ratio has narrowed recently but still probably reflects the higher consumption of alcohol and tobacco by men worldwide. 2/3 of all oral cancers occur in low-income countries, with half of those in South Asia. India, for example, has 100,000 new cases per annum. Rates of oral cancer vary significantly worldwide. High incidence areas include Southeast Asia, Papua New Guinea, parts of Western Europe, e.g., Portugal and France, parts of Eastern Europe, e.g., Slovakia and Hungary, as well as areas in Latin America, e.g., Brazil. The incidence of oral cancer increases with age, with most cases occurring in those over 50 years. The mean age at presentation is 62 years, with a strong correlation between lower socioeconomic class and disease incidence. However, there is an increasing trend for cases affecting younger patients, 45 years or younger, many of whom lack exposure to traditional risk factors. The 5-year survival rate for early-stage cancers is 80%. Despite recent advances, the overall 5-year survival for oral cancer has not markedly improved and remains at 50%. In South Asia, this figure is often below 50%, with a reported 5-year survival of 35% in India. Regional variations. Oral cancer is one of the most common cancers in India, with an age-adjusted incidence rate of 20 per 100,000.1. The disease accounts for over 1/3 of all cancers in India. In contrast to Western populations, cancers of the buccogingival/retromolar area account for over 40% of cancers in India and Southeast Asia, reflecting the commonplace use of the known carcinogens betel quid/gutka, along with smokeless tobacco. In Europe, there is significant variation reflecting the varying cultures and lifestyles, especially between Eastern and Western Europe. Eastern Europe has one of the highest age-standardized incidence rates of oral cancer worldwide, with Hungary recording the highest rates. In these populations, the lateral border of the tongue and the floor of the mouth constitute particularly high-risk sites. In the USA, surveillance, epidemiology, and end results, SER, program statistics indicate that the age-adjusted rate for oral cancer is 11.2 per 100,000 per year, while the number of deaths is 2.5 per 100,000 per year. Risk factors: tobacco, alcohol and betel quid, areca nut, catechu, slaked lime wrapped in a piper beetle leaf, are long-established risk factors for oral cavity squamous cell carcinoma, OCS. There is a dose-response relationship between the use of tobacco, alcohol and betel quid and the development of oral cancer. Transcriptionally active human papillomavirus, HPV, accounts for only a small percentage, approximately 5%, of OCSs, which is in stark contrast to oropharyngeal squamous cell cancers, OPSCs, where 50 to 70% are caused by HPV. Although HPV-positive SCC has prognostic significance in the oropharynx, this survival advantage does not appear to be conferred within the oral cavity. Other risk factors include previous exposure to radiation, chronic infection, immunosuppression and hereditary conditions such as Fanconi anemia and Li-Fraumeni syndrome. Premalignant lesions. The majority of oral cancers do not originate from a pre-existing lesion. However, there are a group of oral premalignant lesions, or more accurately described potentially malignant lesions, that are mucosal abnormalities from which oral cancer can arise. These lesions include leukoplakia, erythroplakia, erythroleukoplakia, proliferative verrucous leukoplakia, PVL, oral submucous fibrosis, oral lichen planus and lupus erythematosus, as well as inherited conditions such as epidermolysis bullosa and dyskeratosis congenita. A leukoplakia is a white patch or plaque that cannot be rubbed off, while an erythroplakia is a bright red velvety plaque, neither of which can be characterized clinically or pathologically as any other recognizable condition. A speckled leukoplakia or erythroleukoplakia is essentially a combination of both. It carries the greatest risk for malignant change. The management of premalignant lesions is challenging, not least because of an inconsistency with nomenclature internationally but also because the natural history of these lesions remains unclear. The reported rates of malignant transformation vary widely between studies and countries. A systematic review of observational studies in 2016 reported that malignant transformation in oral leukoplakia could vary from 0.13% to 34.0%. Risk assessment forms the cornerstone of the management of these lesions. Among these lesions, erythroleukoplakia, PVL and dyskeratosis congenita carry the highest risk for malignant transformation. Clinical factors to be considered include size, location and lifestyle exposure to known carcinogens. Biopsy of lesions is advocated for accurate pathological diagnosis as well as to ascertain the degree of dysplasia, mild, moderate, severe, or indeed the presence of malignancy in a lesion. In this lecture I will discuss the molecular biology of oral cancers. According to the Cancer Genome Atlas, TCGA, alterations in p53, 83%, and CDKN2A, 57%, are the two most frequent genomic mutations noted in HPV-negative cancers of the head and neck, of which oral cancer is an example. This contrasts with HPV-positive tumors, found most frequently in the oropharynx, which have a considerably lower mutational burden and consistently retain p53 wild-type status. It is, however, important to note that, as yet, the current standard of care in head and neck squamous cell carcinoma, HNSCC, including oral cavity cancers, is not based on or influenced by genetic profiling or molecular biology. Staging. Staging is required to document tumor size, location and disease extent, as well as to formulate a treatment plan and facilitate discussion of prognosis with the patient. Additionally, it is an important tool for comparative outcome reporting. The 8th edition of the Union for International Cancer Control, UICC/American Joint Committee on Cancer, AJCC, Tumor Node Metastasis, TNM, Staging Manual, Table 53.1, has introduced changes in how oral cavity cancers are staged. The most significant updates for oral cancer are: I. The inclusion of depth of invasion, DOI, as an element for determining the T stage of primary tumors, and 2. Recognition of extranodal extension, ENE, as a feature necessitating upstaging of nodal disease. This recognition of additional negative prognostic factors in the 8th edition should allow improved stratification of outcomes for patients. T stage. The size and extent of tumors are typically determined by thorough clinical examination, supported by examination under anesthesia, (UA), where necessary, and by radiographic assessment with cross-sectional imaging, e.g., computed tomography, CT, magnetic resonance imaging, MRI. While the DOI can be estimated radiologically, it remains a pathologically determined feature from a surgically resected specimen. N stage. The system for describing the anatomy of regional lymph node metastases has been well described previously lecture. It divides the lateral neck nodes into 5 separate levels, based on their relationship to certain anatomical structures. SCC in the oral cavity and lips tends to metastasize to lymph nodes at levels 1, 2 and 3. However, with SCC of the oral tongue there is a risk of skip metastasis directly to lymph node levels 3 or 4, without the involvement of higher-level lymph node groups. By contrast, tumors arising in the oropharynx commonly metastasize to lymph node levels 2-4, as well as retropharyngeal and contralateral nodal groups. In addition to the number, size and location of involved nodes, ENE has now been included as a contributor to nodal staging. ENE has been reliably shown to be an adverse prognosticator in all oral cavity tumors. M stage. Routine assessment of the chest, as a minimum, for evidence of distant metastasis and/or synchronous lung primary tumors is the norm as part of staging prior to treatment. M0 denotes no distant metastases, whereas M1 signifies distant metastases present. The presence of any distant metastases automatically places a patient in the stage 4C group, currently without curative therapeutic options. In this lecture I will discuss the pathology of oral cancers. The vast majority, greater than 95%, of oral cavity cancers are squamous cell carcinomas, OCSs. The World Health Organization, WHO, tumor grading system, based on cellular differentiation, is routinely used in pathological analysis and diagnosis of OCS. The histological parameters routinely described in OCS include !histological type, !tumor grade/differentiation, !pattern of invasion, !tumor thickness and DOI, !paraneural invasion, PNI, !lymphovascular invasion, LVI, !bone involvement, !nodal metastases. Histological type. The vast majority of OCSs are conventional squamous-type carcinomas, reflecting their cell of origin. Other less commonly encountered variants include papillary, adenosquamous, acantholytic, basaloid, spindle cell and verrucous carcinomas, along with carcinoma cuniculatum. Tumor grade, differentiation. Often cited as an important prognosticator, the WHO grade is based on Broder's original classification and includes well, G1, moderate, G2, or poorly differentiated, G3, grading. The grade is essentially based on how similar the tumor tissue appears relative to the normal tissue from which it originated. In general, well-differentiated OCSs are less aggressive than their poorly differentiated counterparts, which infiltrate and metastasize more readily. Poorly differentiated tumors carry a worse prognosis. Pattern of invasion. The pattern of invasion refers to the shape of the advancing front or border of the tumor. Like tumor grade/differentiation, it is of important prognostic value. The UK Royal College of Pathologists recommends the grading of pattern of invasion into 2 broad categories, cohesive and non-cohesive. Tumor thickness and depth of invasion. Tumor thickness is measured as the maximum vertical dimension between the tumor surface and the deepest point of invasion. Although frequently used interchangeably with DOI, it is the latter that carries greater importance from a prognostic viewpoint as well as the propensity for metastases. DOI is the distance from the level of the basement membrane of the closest adjacent normal mucosa to the deepest point of the tumor invasion. Paraneural invasion. While there is no clear consensus on the criteria for diagnosing PNI, it is generally described as being present if at least 1/3 of the circumference of a nerve is surrounded by tumor cells and/or if deposits of tumor are found in any of the 3 layers of the nerve sheath. PNI is a marker for the biological aggressiveness of a tumor and an independent risk factor for cervical metastases, local recurrence and therefore poorer prognosis. Lymphovascular invasion. LVI represents the presence of tumor cells within an endothelium-lined space, irrespective of whether it is a vein or lymph channel. Bone invasion. 3 patterns of bone invasion, namely infiltrative, erosive or mixed, have been described. There is strong evidence that most tumors enter the bone at the point of contact in an erosive fashion, and not via foramina or the periodontal membrane. It is important to point out that cortical erosion as opposed to medullary invasion does not equate to a T4 tumor. Metastases. As outlined previously, HPV-negative cervical node metastases are associated with decreased overall and disease-specific survival. While skip metastases have been described, most OCS metastases occur in levels 1 and 2 of the neck. ENA occurs when the capsule is breached, and this is now accounted for in the UX/AJCC 8th edition TNM staging system. Distant metastases are rare in OCSs, with reported rates of 2 to 9%, and are associated most commonly with ENA and bilateral neck disease. In this video I will explain about the examination, investigation, diagnosis and workup. These can be summarized as follows. !History and examination. !Biopsy. !Clinical and radiographic staging investigations. !Comorbidity and functional status. !Multidisciplinary team, MDT/tumor board discussion. And treatment plan formulation. !Pathological staging. !Adjunctive treatments if appropriate. When a lesion is suspicious for malignancy, a histopathological diagnosis is essential. Prior to this, a thorough history and examination of the oral cavity, oropharynx and neck should be completed. Radiographic assessment, in the form of a CT and MRI, is also mandatory. In some centers, sentinel lymph node biopsy, SLNB, has become an established technique used for investigation and staging of early oral cancers that have no clinical or radiographic evidence for cervical metastases. A positive SLNB necessitates subsequent management of the neck, typically with completion neck dissection. UA is often used to further assess a tumor, especially in cases where a biopsy is not possible in the outpatient setting or where the extent of the tumor cannot be properly assessed via clinical examination in an awake patient. An UA can support treatment planning and decision-making with regards to access, extent of resection and reconstructive plans. Oral cavity. All sites in the oral cavity are examined under direct visualization. There is wide clinical presentation of OCSs, which range from small areas of erythroleukoplakia to larger erosive and cavitated lesions that invade surrounding tissues. Reduced tongue movement, sensory nerve deficit, trismus, otalgia and dysphagia are all in keeping with late-stage disease. Fibrioptic examination is not routinely performed in oral cavity assessment but may support assessment of the posterior extent of the tumor. The incidence of synchronous primary tumors of the upper digestive tract is 2.4 to 4.5%. The neck. All levels of the neck must be palpated thoroughly to assess for lymphadenopathy. However, it is important to note that, along with clinical examination, cross-sectional imaging of the neck is also required. Clinical examination without imaging has a 74% sensitivity for detecting lymphadenopathy. The presence of a neck metastasis decreases a patient's prognosis by approximately 50%. Biopsy. Primary tumor. Neck lump. Fine needle aspiration cytology, FNAC, is the first-line biopsy for the investigation of neck lymphadenopathy. This technique carries a sensitivity of 89 to 98%. It will help in differentiating between thyroid malignancy, oropharyngeal and oral cavity lesions, utilizing HPV diagnostic tests, and lymphoma. Imaging. Contemporary cross-sectional imaging techniques are essential in the management of head and neck cancer. They inform treatment decisions and prognosis. CT and/or MRI are the gold standard imaging modalities to stage a tumor of the oral cavity. Plain film radiography and ultrasonography, along with positron emission tomography, computed tomography, PET-CT, are useful adjuncts. The aims of imaging are as follows. ! Outline the anatomical extent of the primary tumor, T stage, as well as the resectability of the tumor based on its relationship to vital structures. Histopathological diagnosis via a formal biopsy is the gold standard prior to further investigation and treatment. An incisional biopsy is preferred. It is important to avoid necrotic areas, and a narrow deep biopsy is more useful than a shallow broad one. Other biopsy techniques such as exfoliative cytal augie and brush biopsy lack sensitivity and are therefore not commonly employed. Detection of locoregional metastases. ! Detection of metastatic disease precluding cure. ! Detection of synchronous primary tumors of the lung and upper aerodigestive tract. ! Monitoring of disease response following non-surgical treatment and for detection of disease recurrence. Computed tomography. Contrast-enhanced CT, CCT, typically modern multi-detector slice computed tomography, MDCT, is a commonly available staging tool. This offers the advantage of rapidly acquired spatially accurate cross-sectional images. Hard tissue detail is a particular advantage of CT, relative to MRI. This is particularly important when assessing bony involvement, mandible/maxilla, in oral SCC. CT is also the usual imaging modality for thoracic staging. Magnetic resonance imaging. By comparison with CT, MRI has improved soft tissue contrast resolution and, depending upon specialist radiologist preference, it is frequently the imaging modality of choice for defining the primary extent of oral cavity cancers. Additionally, it offers more information on perineural spread and bone marrow invasion. T1-weighted anatomical images have good spatial resolution, while T2-weighted images preferentially highlight edema and therefore pathology. MRI has a sensitivity of 82% and specificity of 66.7% for the detection of bone/bone marrow invasion in the mandible. The ability of MRI to detect neck metastases is comparable to that of CT. Positron emission tomography combined with computed tomography. PET-CT is not a first-line imaging investigation for head and neck cancer, and its use is usually restricted to detection of distant metastases or synchronous tumors, investigation of tumors of unknown primary and post-treatment surveillance. Plain film and panoramic radiographs. Plain film or panoramic radiographs can be helpful in defining gross bony involvement during tumor staging. However, their main utility is for evaluation of the dentition to plan essential prophylactic dental treatment and highlight infection or inflammation. Ultrasound. Ultrasonography is a non-invasive, chairside investigation that is now most commonly used to guide FNAC sampling of suspicious lymph nodes. It is operator-dependent but in experienced hands is very useful in the detection of lymphadenopathy. It is of limited value in investigation of oral cavity tumors. It has 85% sensitivity and 78.9% specificity for cervical lymphadenopathy. Sentinel lymph node biopsy. Sentinel lymph node biopsy, SLNB, has become a recognized technique to support staging of the neck in patients who do not have clinical or radiological evidence of lymph node metastases, CN0. The sentinel node is the first node to which cancer cells are most likely to spread. SLNB seeks to determine the presence of nodal metastasis within the first draining nodes and guides the necessity, or otherwise, for further treatment of the neck. There is robust evidence that, in patients with a T1/2 oral cavity SCC, performing a prophylactic elective neck dissection as opposed to adopting a watch-and-wait policy leads to superior overall and disease-free survival. 3 However, not all patients will have nodal metastases, and as such, provision of a neck dissection for all will inevitably result in overtreatment of a significant proportion. SLNB can be utilized to highlight those patients with occult metastases and who can then proceed to formal neck dissection. Additionally, SLNB may demonstrate unexpected contralateral lymph node drainage that would not otherwise have been identified or treated. Despite its potential benefits, the SLNB technique has a false negative rate of 14.4% to date. Evidence providing a comparative analysis of elective neck dissection versus SLNB, where survival is the primary endpoint, is still lacking. In this video, I will discuss the surgical management. Surgery, with adjuvant radiotherapy, or chemoradiotherapy, if indicated, remains the mainstay for management of oral cavity cancer. Over time, surgical techniques have evolved to become more refined with a greater emphasis on function-sparing techniques and a move away from more radical procedures. Reconstruction of postablative defects with an associated improvement in quality of life is a cornerstone of the surgical management of oral cavity cancer. This evolution in surgical management has been influenced by an improved understanding of tumor biology, more accurate staging investigations, and microvascular free tissue transfer reconstruction. Overall and disease-specific survival is largely dictated by tumor biology, with features such as nodal metastases with ENA of greatest importance. Notwithstanding this, surgeons can optimize the outcome for patients by considering the following principles. Patient selection. Key surgical decisions. Reconstruction. Multidisciplinary care. Patient selection. As outlined previously, patients' comorbidities and functional status as well as their social circumstances play a significant role in their ability to tolerate surgery and rehabilitation. The early involvement of an MDT, including physicians, anesthetists, physiotherapists, and dietitians, is important, particularly in high-risk patients, in order to optimize their performance status preoperatively. The operability of a tumor is determined largely by its size and relationship to important anatomical structures of the head and neck. In the AJCC 8th edition TNM staging system, T4B tumors are those that may be unresectable owing to involvement of or proximity to the skull base, masticator space, pterygoid plates, and/or the internal carotid artery. Key surgical decisions. Once the decision has been made that surgery is appropriate, a few key decisions are to be made. These are as follows. Airway management. Access to the tumor. Tumor resection. Management of the neck. Reconstruction. Airway management. Airway management in patients undergoing surgery for OCS is largely centered on protecting the airway against acute embarrassment in the perioperative period. The available options are immediate postoperative extubation, overnight intubation/delayed extubation, submental intubation, and tracheostomy. The choice of airway is a joint decision made between the anesthetist and surgeon, and is influenced heavily by the ability to re-establish a patient's airway quickly should a life-threatening event occur. Immediate postoperative extubation is generally reserved for smaller, well-lateralized tumors in uncomplicated patients who may not require reconstruction. In selected patients, overnight intubation is considered when tracheostomy is unlikely yet can still be cited on postoperative day 1 if warranted. This approach is burdensome on resources given the higher level of care for the first night, but it reduces length of stay via a quicker restoration of speech and swallow. A low threshold for placing a tracheostomy is appropriate in patients having a bilateral neck dissection or previous neck dissection, large resection with reconstruction, and in patients with a difficult airway. Consideration should also be given to placing a tracheostomy in patients having a segmental mandibular resection, lateralized resections involving the floor of mouth and reconstruction, as well as previously irradiated patients. Access surgery. The goal in surgical management of OCS is to remove the tumor with an adequate margin circumferentially. While most tumors can be removed via a transoral approach, some cannot be resected safely without an access procedure. These might include large maxillary tumors, posteriorly located tumors and tongue-based tumors, or patients who have previously had surgery and/or radiotherapy. The most commonly used access procedures include the lip split mandibulotomy, LSM, figure 53.5, the mandibular lingual release, the visor flap, and the Weber-Ferguson approach, figure 53.6, which provides excellent access to the maxilla and, if extended infraorbitally, to the periorbital area. Lip split mandibulotomy. This is the most commonly used access procedure and provides excellent access to the posterior oral cavity, tongue base, and oropharynx. It involves making an osteotomy in the mandible in order to swing it laterally, thereby facilitating access. Care must be taken to ensure that the lingual mucosa does not tear in an uncontrolled fashion towards the tumor resection margin. Tumor resection. The gold standard in OCS is resection with a 1 cm clinical margin circumferentially, vital structures permitting. Mandibular resection. Decisions regarding management of the mandible when tumor lies close to, abuts, or invades the bone are critical. If there is evidence of infiltrative bone invasion, either segmental or rim resection of the involved mandible is required. Segmental resection involves removing the full height of the invaded section of the mandible such that there is loss of continuity of the lower border. Rim resection or marginal mandibulectomy involves removing a partial thickness of mandible such that continuity of the lower border remains. A rim resection is sometimes performed when a tumor lies close to but does not definitively invade the mandible, in order to achieve a satisfactory soft tissue margin. Maxillary resection. Owing to anatomical differences such as thinner bone, the presence of sinuses, tightly adherent palatal mucosa, and proximity to the orbit and skull base, maxillary resection considerations differ from those in the mandible. Small tumors of the maxillary alveolus can be managed by transoral partial maxillectomy. More extensive tumors involving the floor of the maxillary sinus require wider access by a Weber-Ferguson incision. If the preoperative investigations demonstrate extension of the disease into the pterygoid space or the infratemporal fossa, the prognosis is poor as surgical clearance is difficult or not possible. Tumor extending into the orbit requires simultaneous orbital exenteration or, in some instances, a combined neurosurgical resection. The various methods of maxillary reconstruction can be guided by the extent of resection and tissues involved. Reconstruction seeks to provide an oral seal and restore facial profile and tissue loss, while facilitating a means to achieve dental rehabilitation. Management of the neck. In surgical terms, management of the neck refers to a neck dissection, elective or therapeutic. In patients with clinical and/or radiographic evidence of cervical metastases, treatment of the neck in the form of a therapeutic neck dissection is indicated. Primary radiotherapy is less common. In patients with early-stage disease and in whom there is no clinical or radiographic evidence for cervical metastases, there is now strong evidence showing that patients who have an upfront or elective neck dissection have better overall and disease-specific survival relative to patients who have a watch-and-wait policy and a therapeutic neck dissection only when a metastasis becomes apparent. 5-SLNB can be utilized as a staging investigation to better guide the indications for a neck dissection in the setting of a small tumor where occult metastases may still be present. Over the last 100 years, neck dissections have evolved to achieve a less radical extent as evidence emerged for the oncological safety of more selective or nuanced procedures. 6 For elective neck dissections, a selective neck dissection involving levels I3 of the neck is indicated for the management of OCS. 7 A neck dissection is performed not only to stage a disease and aid prognosis, but also for therapeutic purposes as well as informing the need for adjuvant therapy. Additionally, it provides access to recipient vessels within the neck, which may be used in microvascular free tissue reconstruction. In this video I will explain the reconstruction. Reconstruction following tumor ablation is a key component in the management of OCS. Decision-making with regards to reconstruction should not influence the ablative procedure. Notwithstanding the importance of facial aesthetics, preservation or restoration of speech, chewing, swallow and oral continence are of paramount importance. The oral cavity is a unique site. It contains hard and soft tissues, including the dentition, is bathed in saliva and is anatomically complex. It is the opening to the aerodigestive tract and has a multitude of motor and sensory nerves. Like any defect, reconstruction of the oral cavity should aim to replace resected tissue with similar tissue. The reconstruction ladder is a useful algorithm and can be applied to the oral cavity. Additionally, general reconstruction principles apply, namely, use the simplest method that will meet reconstruction aims, replace lost tissue with similar tissue, consider vascularized tissue in a previously irradiated recipient site, and always have an alternative should your primary reconstruction fail. While free tissue transfer, free flaps, has revolutionized reconstruction following ablation of an OCS, there are instances, for example owing to patient comorbidities, where a local or regional flap is appropriate. Owing to the extensive and consistent blood supply in the head and neck, local flaps in this region are safe and predictable. Smaller defects not requiring substantial soft tissue or bone for reconstruction can be reliably reconstructed with flaps such as, but not limited to, the facial artery myomucosal, FAMM, nasolabial, buccal fat pad, tongue and palatal flaps. Regional and pedicled flaps include tissues from other parts of the head and neck, such as the temporalis and platysma flaps, as well as those from more distant sites such as the latissimus dorsi, delta pectoral and pectoralis major flaps. Free flaps. A free flap is a portion of vascularized tissue harvested from a distant donor site and transferred to an area requiring reconstruction where its artery and vein are anastomosed locally, thereby providing an independent blood supply. Most tissue types, including skin, fascia, muscle, tendon and bone, can be harvested. Therefore, within the oral cavity both bone and soft tissue can be replaced with similar tissues. Soft tissue reconstruction. In oral cavity reconstruction, common soft tissue flaps used include the radial forearm free flap, RFFF, figure 53.8, and anterolateral thigh, ALT, flap. Alternative soft tissue free flaps include rectus abdominis, latissimus dorsi, medial sural artery perforator and lateral arm flaps. The relative merits of these flaps are outlined in Table 53.5, Composite Reconstruction. The fibula is the most commonly used bone-containing, composite, flap globally, while the iliac crest, DCIA, scapula, including tip of scapula, and composite RFFFs are also used, each carrying specific pros and cons. Chimeric flaps, where osseous and soft tissue components are independently mobile, e.g., the thoracodorsal system of free flaps, are advocated for certain complex reconstructions. Reconstruction by anatomical subsite. Soft tissue reconstruction. Intraorally, this includes the tongue, floor of the mouth, buccal and retromolar mucosa as well as the soft palate. As outlined previously, the most commonly used soft tissue flaps are the RFFF and ALT. The RFFF provides a thin, non-hirsute and pliable flap with a long vascular pedicle and so can be useful where significant bulk is not required. The ALT, however, owing to its increased bulk, is far more suited to tongue reconstruction where bulkiness is crucial in creating a seal between the oral cavity and soft palate during speech and swallowing. The ALT also facilitates multiple skin paddles and/or muscle components, where necessary mandible reconstruction. Reconstruction with composite-free flaps is now the gold standard for segmental mandibular defects, figures 53.10 and 53.11. The choice of flap is varied and depends on factors including the site, size and complexity of the defect, patient comorbidities and indeed surgeon training and preference. While it is possible to leave small posterior sites unreconstructed, reconstruction of an anterior defect is particularly important and challenging in order to achieve satisfactory function for the patient. The following general principles may help to plan mandibular reconstruction. Reconstruction of the anterior mandible is always more challenging. Although the lengths of the bone and pedicle are often cited as factors in choosing the donor site, the average defect is 6 to 10 centimeters and usually immediately adjacent vessels for microvascular anastomosis mean that these are not usually an impediment. Use the curvature of the chosen bony flap to follow the natural shape of the mandible, thereby reducing the number of potential osteotomies. In an edentulous case, it may be helpful to slightly reduce the span of the mandibular segment to avoid a resultant class 3 appearance, where the mandible protrudes beyond the opposing maxilla, giving a very prominent chin position. Free bone can become a nidus for persistent infection, particularly following radiotherapy. Maxillary reconstruction. The main aims of maxillary reconstruction are as follows. Restore facial contours and aesthetics. Separate sinonasal cavities from the mouth. Restore soft palate competence to facilitate speech and swallowing. Restore/provide for replacement of dentition. A classification system for maxillary defects is useful for both treatment planning and discussion with colleagues. The most widely adopted classification is that proposed by Brown and Shaw. This classification considers both the vertical and horizontal extent of the defect. Classes IV describe the increasing size in a vertical dimension, while the horizontal extent is described by the letters AC. Although not absolute, one of the advantages of this classification system is that it implies management. Class I defects are easy to repair with the only reconstructive requirement being to separate the oral and nasal/antral cavities. Local flaps are often satisfactory, and the RFFF is the most commonly used free flap. Class II defects can be restored in a similar fashion to Class I, especially when more posteriorly located. However, composite, bone-containing, free flaps are usually required for anterior defects, and classic defects, as well as situations where the existing dentition is not adequate to retain a prosthesis. In classes 3 and 4, support for the contents of the orbit is lost, as well as support for the anterior cheek and alveolus. A prosthesis alone will provide a suboptimal result. The reconstructive goals are to support the orbital contents and facial skin, ensure bony continuity between the remaining alveolus and zygomatic buttress, ideally sufficient to facilitate endo-osseous implant placement, as well as seal the oral and nasal cavities. Therefore, a composite free flap, e.g., the thoracodorsal free flap, is suitable for fulfilling these requirements. Evolution in zygomatic implant technology can support prosthetic rehabilitation and restoration of low-level maxillectomy defects in combination with soft tissue flaps. In select cases, this can remove the necessity for composite-free flaps. It should be pointed out that prosthetic reconstruction, using an obturator denture, of a maxillary defect remains a reasonable and sometimes appropriate alternative to free tissue reconstruction. However, studies have shown that free flap reconstruction results in improved functional and aesthetic outcomes when compared with prosthetic obturation. Zygomatic implants and zygomatic implant perforator. ZIP, flaps. zygomatic as well as oncological or coaxial implants, used in conjunction with a fixed or removable prosthesis, or indeed with a free flap, have improved our ability to quickly restore dentition post-maxillectomy. Recently, the use of zygomatic implants that perforate a soft tissue-free flap, used to close an oroantral/oronasal communication, and placed immediately after tumor ablation has been described. Virtual surgical planning. The use of virtual surgical planning, VSP, in oral cavity reconstruction is increasing. Potential benefits include reduced operating time, greater accuracy, and improved aesthetic/functional outcomes. Patient-specific surgical stents and cutting guides for both the tumor and donor sites are made preoperatively, based on CT scans and software. The surgeon performs the surgery virtually, based on the resection and therefore the size and shape of reconstruction required. Cutting guides are provided for both the oral resection and donor site harvesting. Prefabricated reconstruction plates can also be made. In this, I will discuss the adjuvant therapy for the management of oral cavity cancer. While primary chemoradiotherapy can be offered to patients who are unsuitable for or refuse surgery, primary surgery, with/without adjuvant, chemoradiotherapy, is the standard treatment for oral cavity cancer. Adjuvant therapy is given based on pathological features of the tumor. Radiotherapy is administered typically via external beam radiotherapy. In high-risk cases, chemotherapy, usually cisplatin-based, is included as a radiosensitizer within the adjuvant regime for suitably fit patients. As outlined in previous sections, the adverse pathology cal features associated with locoregional recurrence and decreased overall and disease-specific survival include ENA, close/involved margins, LVI and PNI. It is these, among other, adverse features that inform the decision to administer adjuvant therapy. While there is no absolute international agreement regarding the criteria for radiotherapy, the current consensus is that one major criterion, ENA and/or involved margin, less than 1 mm, or two minor criteria, close margin, 1 to 4.9 mm, multiple involved nodes, largest node greater than 3 cm, LVI/PNI, T3/4, would indicate the need for adjuvant radiotherapy. 8. Adjuvant chemoradiotherapy. The landmark RETOG 9501 and EOR 22931 randomized trials form the basis for the contemporary role of adjuvant chemotherapy, CRT, in high-risk OCS, although only 25% of recruited patients had OCS. These studies looked at the benefit conferred by adding high-dose cisplatin to conventional postoperative radiotherapy, RT, with primary endpoints of locoregional control and progression-free survival, respectively. Positive surgical margins and extracapsular extension, EKI, now ENA, were used to classify patients as high risk in both studies, while several other criteria unique to each were also investigated. Ultimately, and following several associated long-term, subgroup and pooled analyses, these trials provided strong evidence for the use of concurrent cisplatin-based CRT in high-risk patients. Immunotherapy. Anti-tumor immunotherapy is based on the principle that tumors can sometimes escape immune response/checkpoints owing to adaptations in immune surveillance and the tumor microenvironment. Immunotherapy represents a change in the treatment paradigm. The pathway of the programmed death receptor 1, PD1, and its ligand, PDL1, has become an increasingly important target for immunotherapy in HNSCC. The receptor-ligand interaction is a major mechanism used by tumors to evade the immune system. Multiple randomized Phase 3 trials have demonstrated that exposure to a PD-1 inhibitor prolongs survival in recurrent or metastatic HNSCC. These results, among others, highlight the potential for research assessing the role of checkpoint inhibition in the management of HNSCC. Management of recurrent and/or metastatic disease. Patients with a low burden of disease or oligometastatic deposits and a satisfactory performance status can be offered salvage surgery and/or radiotherapy with curative intent. Patients with a recurrence not amenable to surgery and/or radiotherapy are eligible for systemic treatment. Current standard of care options depend on previous exposure to platinum-containing chemotherapy, but include both immunotherapy and palliative chemotherapy regimens. Nonetheless, the poor prognosis for these patients remains. This video lecture is very important for MBBS, BDS students and postgraduate students for their final examination preparation about the oral cavity cancers. If students carefully listen this lecture, they will be able to attempt all types of MCQs and short essay questions for surgery examinations. The students are advised to listen this lecture multiple times and solve the MCQs and university questions about oral cavity cancers.